Hello everyone. My name is Satoshi Abiko. I am first author of this article. I'd like to thank you for giving me the chance to speak here. I introduce this article to you.
The name of this article is Feasibility of a new ligation using the double loop clips technique without an adhesive agent for ulceration after endoscopic submucosal dissection of the colon, with video. Background and aims. Several ligation techniques for ulceration after endoscopic submucosal dissection (ESD) have been reported, but none have been established for clinical use because of technical complexity and requirement for expensive equipment. Therefore, the technical feasibility of a new ligation using the double loop clips (DL clips) technique without an adhesive agent for ulceration following ESD of the colon was assessed. Methods. Among 35 patients who underwent ESD of the colon in Kshirorose Hospital between April 2019 and September 2019, 26 patients who underwent ligation using DL clips technique for the post-ESD ulcer bed were included in this retrospective study. Next, please watch the video. Video showing the ligation using modified DL clips technique. Now, let me begin.
How to make a modified DL clip. Tape two needle caps to a board. Place the board between your knees. Take a thread and wrap it around the top needle cap. Tie the thread. Turn the board around and create a new loop around the second needle cap. Tie a knot and cut off the excess thread. Remove the loop from the needle caps. The modified DL clip is created.
This is a short clip. The clip is deployed. Modified DL is attached to the short clip. The clip is drawn back. Ligation using the modified DL clips technique for ulceration following ESD of the colon. 36 mm in diameter. Two pre-existing clips were placed for two pulsating exposed blood vessels. The modified DL clip is deployed. The modified DL clip is applied to the inner side of the post-ESD ulcer area. Application of a different clip to the proximal loop line. The proximal loop line is picked. Clipping of the mucous membrane on the oral side. Aspirate air, 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 and clipping. The second modified DL clip is deployed. The second modified DL clip is applied to the inner side of the post-ESD ulcer area. This time, the distal loop line is picked because the proximal loop line cannot be. The distal loop line is picked. Clipping of the mucous membrane on the oral side using the same technique. Aspirate air, aspirate air, aspirate air, and clipping. A clip is then added to tighten the ligation, thereby completing the ligation. Results: the rate of an block ulcer resection was 97.1%. The median length of the resected specimen was 3.2 cm, and the complete ligation rate was 88.5%. Excluding patients with lesion site in the rectum below the peritoneal reflection, the complete ligation rate was 95.5%. The median duration of ligation procedure was 20 minutes. The only delayed procedural adverse event was post-ESD coagulation syndrome in one patient. This slide shows the characteristics of patients with complete and incomplete ligation. Incomplete ligation was significantly more frequent in patients with a lesion site in the inferior rectal valve/anal bulge area. Conclusion: ligation using the DL clips technique without an adhesive agent is feasible for closing ulceration following ESD of the colon, whereas other techniques may be necessary for lesions in the rectum below the peritoneal reflection.
Thank you for your kind attention.